Well, I'm Dr. Jim Del Rosso, the editor-in-chief of the Journal of Clinical and Aesthetic Dermatology, and it seems like yesterday that we were recording the highlights from the April 2026 issue. And now here we are talking about May 2026, jam-packed with very valuable information for dermatology clinicians. So I want to start by addressing in this May issue the Residents Corner. And I do want to thank Arcutis for supporting this particular corner of the journal. And this month, we have patient-centered communication, the most underrated procedure in dermatology. And who else to better comment on this is the man who is everywhere in dermatology providing education, and that's Dr. Diego Ruiz de Silva, who practices in Virginia Beach. And I'm happy to say that he's very involved with this journal, very supportive on many levels. I think this Residence Corner is very important because it discusses with residents the idea that, when you're in training, you're trying to soak up so much scientific information and be brilliant in dermatology. And that's reading textbooks, preparing for being asked scientific questions when you're in a group of people at grand rounds or whatever the case may be. And it really held to the science, the disease state, what's the mechanism of the disease, the different treatments, what the efficacy, the safety. It's really focused on the scientific aspects. But so much of what we do in clinical practice, and there's more of a spotlight centered on it now because patients can go to social media and they can tell you what they demand, and they're not very light on that in what they say out there. So it really talks about being sure you're focused on paying attention, observing the clinicians you work with, even your co-residents, in how they speak to patients, how they handle certain challenges. So the first thing he says is diagnose the emotion, not just the rash. Right. Replace authority with partnership. Yes, you are the person they're coming to get recommendations on treatment and to evaluate them, making sure the diagnosis and treatment are helpful to that individual. But it's the demeanor that you're presenting. It's not this white coat, austere, dogmatic individual that just says, this is what you need to do, walks out of the room, and then it's over. Sort of like the doctors were years ago when I was a little kid, and I'm 72 now. Things have changed, and it doesn't diminish your expertise, but it's the demeanor that you're presenting to the patients. There's a lot of immunology that we have to know, but we have to translate why we're doing what we're doing in a way that's meaningful to the patient. So he talks about translate immunology into humanity. Be mindful of nonverbal communications. Are you is your hand on the door while you're talking to them? Or are you making eye contact? I like to sit down and actually be looking at them eye to eye or a little bit up toward them so they feel like they're having a conversation, not by someone who's bossing them around, but someone who's interested in why they're there that day. Manage expectations early and address the stigma that can be related to the disease that the patient might be dealing with that we often don't think about or they don't translate. A lot of this, you can have your staff help you gather this. And then the long game, how you develop trust. And this is often in how they're reading you. You're are you really genuinely interested, or is it just a dog and pony show? And so really, I think all of this is very important. And I think he did a great job on this particular Residence Corner. So thank you, Diego. Next is a letter to the editor, which I think is very, very interesting. Okay. It comes from Courtney Chow, Marqueta Saint Araman, Kelly Barta, Cheryl Barry, and the illustrious Dr. Peter Leo. Okay. And it's about complementary and alternative medicine to treat dermatologic conditions. And this is becoming more and more prominent. Patients talk about it. They're looking for ways other than medications to help them with their disease. They're reading a lot of information, some that's very scientifically sound, but a lot of it is opinion out there from a variety of different individuals. So it's very timely. How much science is behind all of it varies. In fact, sometimes there isn't a lot of science, there's perception, but other times there is. And they talk about dietary supplementation. People are very attuned to their diet. And the whole issue that has a lot of scientific data to show that there are problems, the whole issue of processed foods versus fresh foods, and actually different types of foods you're eating, whether weight loss has a particular impact on a disease, not only to make people feel better about losing weight, but connected to the pathophysiology, which we know has ties to hidradenitis suppurativa, psoriasis vulgaris, and many other diseases. So this is a very important topic to pay attention to. They go through the views in the United States versus outside of the United States. And they really show that a lot of the attention is really more outside of the United States. Within the United States, I think there's more demand on many levels. I want the scientific proof as to why you're recommending XYZ diet or supplement or something else that I should be doing. But the bottom line is across the board, is people are not necessarily looking to replace traditional therapies that have a lot of science behind them, but are looking for alternatives. So I think it's important we just don't say, oh, this is a lot of hogwash, we don't have enough data on it, and really develop an attitude that's not going to get us in good connection with our patients because they are interested in this type of information and they're interested in our opinions that are not just reflex reactions to it, but that we're spending some time thinking about this information. So I think that's very, very important. A couple of the other articles I think stand out. One I have to call attention to is by Mojan Duris, and Mojan is a physician assistant that's actually now in medical school here in Las Vegas, and she did an outstanding job on an article that I co-authored with her with Dr. Natasha Mezenkovska, the concurrence of atopic dermatitis and alopecia areata, and she did by far the heavy lifting. How common is this? Why does it happen? How is it managed optimally in clinical practice? And we see a lot of patients that have both atopic dermatitis and alopecia areata. A lot of them are younger individuals, but not always, right? They may be below the adolescent age group. They may be adolescents. They can certainly be adults. And there's an excellent explanation as to why this seems to happen in these individual patients and how to address the issue of managing these patients. So I'd strongly recommend, I'm sure most of you, if not all of you, treat atopic dermatitis and alopecia areata. This brings that topic together. And she did a fantastic job. A couple of other articles. One that really stuck out to me. Now, I don't do cosmetic dermatology and I don't inject fillers, but I'm pretty aware of what goes on with those particular patients. And this is an article on hyperbaric oxygen therapy in the management of dermal filler induced vascular occlusion. That's a nightmare to us. If a patient has an occlusion of vessels while they're having a filler injected, that is a cosmetic dermatology emergency. And it's a review of the use of hyperbaric oxygen therapy. Now, for myself, having done a lot of cutaneous oncology and Mohs micrographic surgery for many years, I would recommend hyperbaric oxygen to patients that had very large wounds that was slow to heal on the lower extremity. either from surgery or sometimes as a sequelae to radiation therapy. And the hyperbaric oxygen, if you could find a facility that was amenable to work with and get the patients in a timely fashion and work on the insurance coverage, so you develop a relationship with one or a few centers if you don't have it right there with you, close by, with in your facility, whatever the case may be. This is not a common problem. And in looking at where the hyperbaric oxygen therapy was utilized, it was all over the place. There wasn't any particular standardized regimen. There wasn't any particular sense of this is the best way to do it or how to do it. There just were not enough cases. So I think there are some suggestions in here of where it might be something to go to, but we certainly need more information. It's adjunctive to the standard measures that we would normally use, like hyaluronidase, antiplatelet agents, vasodilators, thrombolytic therapy, how the individuals that are injecting fillers handle those vascular complications. But this is certainly an adjunct to be thought about. What really stood out to me was table three, which talks about the clinical differences amongst arterial ischemia, venous congestion, and bruising. So it gives several tips on how to distinguish those. Maybe it's just a bruise and it's not this emergent situation. I found that table, if nothing else, to be very, very valuable. So would suggest going to that if you inject fillers. Now, two articles on tildrakizumab, which is the selective interleukin 23 P19 inhibitor that I felt were valuable. One is the efficacy and safety of tildrakizumab in elderly patients with psoriasis, a narrative review, and it talks about how patients that are uh, 65 years of age and older make up about 10 to 13% of the populations in the clinical trials. And they talk about clinical trials, which include the standard clinical trials and also trials that are based on real world evidence, and they go through those. In the clinical trials, it was inclusive of 165 patients. In the real world evidence studies, it was 134 patients. And basically, the summary is that tildrakizumab works equally as well in patients that have moderate to severe plaque psoriasis, in patients that are 65 years of age and older, as compared to those that are younger. There may be some advances to tildrakizumab based on the methods of insurance access and in the Medicare population. Uh, and it goes through a variety of different of those considerations. So if you're treating psoriasis, moderate to severe plaque psoriasis, this is something to pay attention to as an option. The second one is real-world effectiveness and safety of tildrakizumab in patients with moderate to severe psoriasis after they failed ustekinumab, which ustekinumab is an anti-IL-12/23 inhibitor. So there is some mechanistic difference as compared to tildrakizumab. They looked at 14 patients that had not responded adequately to ustekinumab, and they had very favorable responses to tildrakizumab. It's a small number of patients, but it does show that it can be an option in those patients that would be effective, even though seemingly it may look like they're working by the same mechanism. And technically, and and if you look at it, ultrastructurally, they are not. The next article is a case report, and I think it's a valuable case report because it has a differentiating feature. Resolution of long-standing irritable bowel syndrome symptoms after treatment of psoriasis with risankizumab. And the senior author is a friend and colleague here in Las Vegas, Dr. Graham Lichman. Also, we have the lead author is Jose Gaspar de Alba. Marley Catrona, Ahuva Sitches, and again, Diego Ruiz de Silva are the authors of this paper. What distinguishes this paper is we typically are talking about inflammatory bowel disease as a potential comorbidity or another disease state that's present in patients with psoriasis and how that may affect the therapy that you're utilizing. This is irritable bowel syndrome. And it's interesting that the patient had long-standing irritable bowel syndrome, which is very different than inflammatory bowel syndrome, either Crohn's disease or inflammatory bowel disease, right? Um, it very different. The irritable bowel syndrome symptoms resolve. So I think that's of interest because even though they're distinctly different, we don't typically hear much discussion about that, right? And a couple of other articles that I think are worth mentioning that they are in the journal. I'm not going to review them, but just so you know, there's the protective effects of an advanced antioxidant serum and an encapsulated vitamin C serum from ultraviolet induced erythema and oxidative stress. That that something in the cosmeceutical world that might be of interest to you. If you have the kind of practice that wants to get feedback from your patients before you see them. This is an article, Aligning Care to Cognitive Style. It's a four-question uh, questionnaire that's a framework for patient-centered dermatology visits. It's given to patients ahead of time and it asks them four questions. So you could look at in advance what they're interested in, what their attitudes are coming in before you even see them, on what their expectations are from you as a practice, as a clinician, and as a staff member. Interesting that they came up with that kind of questionnaire, but that is the era we live in. Patients have a lot of expectations before you walk into that treatment room. So this might help. There's also another interesting one from Era to Insight, and it's a curriculum tool for resident education looking at patient safety, quality improvement, and adverse event disclosure. And it works through how to get residents up to speed in these particular areas. So it might be helpful in those interested in resident education. And then another article, Review of Skin Depigmentation Practices and Cutaneous Malignancy, focusing on individuals with skin of color. And it's an interesting question because pigmentation in skin is part of the protective barrier against ultraviolet light exposure. And if we're applying products to depigment the skin, is that altering that level of protection? Well, we don't really have a perfect answer on that, but this article addresses that particular issue. But really, there's not a lot of data when you look at specifically the increase potential increased risk in something like squamous cell carcinoma. They had a very small number of patients where that was thought that that might have been a risk. And the most common bleaching agents that were used were topical clobetasol and hydroquinone. These cases were primarily from Africa. Those are not treatments that we're using as standard recommendations for depigmenting uh, skin in the United States in any particular patient. But some patients might still be getting those particular therapies. It's an interesting read. I don't think we have all the answers yet, but it raises the question of something we need to be looking at prospectively in in trials in the future or by real world evidence. So that sums it up. I may have missed a couple of things, but that's actually a hint for you to go look at the journal yourself and read it. And I think you'll find it very valuable. Thank you very much, and we'll see you next month.